What I wanted to talk about is whether the depression causes the pain or the pain causes the depression or something else, because I get asked this question more often than any other question, and we'll come to that. So how commonly do depression and chronic pain occur together? Does the pain cause the depression or depression cause the pain? What does depression add to chronic pain? And is treating the pain adequate to treat the depression? At least these issues we'll cover. So the definition of major depression has not changed in any significant way since DSM-3 came out in 1980. The two core symptoms remain either depressed mood or loss of pleasure, meaning that people are not enjoying things. Particularly, they're not enjoying their favorite things. And these symptoms, most importantly, are relevant whether people attribute them to pain or not, as long as they have the enduring and persistent low mood or loss of pleasure. I often find it useful to ask, if somebody can't play golf because their back is hurting, then I ask about whether they enjoy watching movies or whether they like playing bridge or they like seeing friends, things that are not quite so directly affected by their mobility. And it should be a fairly pervasive loss of pleasure to qualify for this cardinal symptom. And then major depression also should be accompanied by 4 of these other symptoms, which in my mind indicate that this has gotten to be kind of an enduring, perhaps neuroendocrine or at least physiological phenomenon that is not simply a bad day, and it's become somewhat self-perpetuating when you have, alterations in appetite and sleep, and whether you're agitated or slowed down and you can't concentrate, and maybe feeling worthlessness or guilty and hopeless or suicidal. So these are old prevalence numbers, but pretty accurate still, meaning that as you move from a door-to-door kind of general population survey where there's 2 to 4% qualifying, into outpatient clinics you get a doubling, into inpatient settings you get another doubling of the rates, so that yes, medical illness in general is a stressor that increases your risk for depression, and pain clinics, it's been a little tough to get a stable estimate because certainly depression is overrepresented there, and sampling characteristics, I think, affect these numbers more than separate pain conditions having all that much unique relationship with depression. But certainly people who get to specialty pain care, more than half of them meet criteria for major depression. So there's been a lot of look. This is also a little bit old data, but it gives a good sense of the fact that there's a lot of pain complaints in depressed patients. These studies have a range of 15 to 100%, about 65% or 2/3. And it doesn't really matter whether you're seeking out the depressed patients in psychiatric or in primary care settings. And then there's even more studies of depression and chronic pain, and as you can see, they vary from about 1/4 up to 3/4 of people noting depression when they have chronic pain. So I think a fair consensus estimate of more than half is fine. When you drill down into a bit more of the details, if you get pain, you end up with about 2 to 5 times the depression risk. That's particularly true if people have multiple pain complaints or multiple episodes of pain or severe pain. We're around here quite convinced by the research coming out of Dan Claw's group at the University of Michigan that people who have multifocal pain combined with mood, sleep, and cognition problems are a different group than people with a single focus of chronic pain. And that recent work is consistent with this older work suggesting that multifocal and multi-episode pain is more likely to be associated with depression. And then if you add the depression in, people also then tend to have more pain complaints, more pain intensity, and more pain chronicity. The two really feed off of each other. And the best study I think about this is now also kind of an older study that was a multinational WHO-sponsored study of nearly 5,500 patients, so 15 sites in 14 countries. They found that about 22%, or 1 in 5, primary care patients have persistent pain that has been going on for 6 months, that is associated with seeking health care or having disability in a major life activity. So this is significant pain. It's not, occasional or mild or the kind of pain you can just ignore. 1 in 5, and that's a well-replicated number. And this group is about 4 times more likely to have an anxiety or depressive disorder than that group without persistent pain. And in fact, that relationship between pain and these anxiety or depressive disorders is actually more consistent across cultures than the relationship between the pain and the disability. So it's a pretty robust international finding. They followed up a subset of nearly 3,200 patients, same 15 sites in 14 countries. They were seen at baseline, which is what I just showed you, and then 12 months later. And they found that at least 50% of the people who had 6 months of pain at baseline still had pain 12 months later, and that was predicted by this number of pain sites at baseline. So that's a very important thing to note about your patients, is how many pain sites they've got. About 9% had new onset of persistent pain. That means by 12 months they had accumulated at least 6 months of pain, and that was predicted by psychiatric disorder, perceived poor health, or occupational role disability at baseline. And in fact, that's how the investigators summarized this. They basically said persistent pain at baseline predicted the onset of psychological disorder with the same strength that a baseline psychological disorder predicted the onset of persistent pain. So the answer to whether does the pain cause the depression or the depression cause the pain, the answer is yes. That pretty much any relationship that you can think of between the two has an evidence-based. And if you factor in whether people are disabled by these conditions, that strengthens the association between pain and depression. So, chronic pain, unfortunately, makes depression harder to treat. We know that from SSRI trials. For example, the ARTIST efficacy trial of 573 patients, risk for poor treatment response went up in a linear fashion from those with mild pain who were, had 1.5 times the risk of not responding, 2 times the risk for those people with moderate pain, and 4 times the risk for people with severe pain. So significant to a straight SSRI trial. But even to more flexible and multimodal care, such as used in the IMPACT trial, which included flexible antidepressant treatment and psychotherapy with problem-solving therapy and care management with the nurse, even in that group, about 49% of people with no or low pain interference responded, but only 37% of those who noted high pain. So it inhibits response even to that more flexible and robust depression treatment strategy. In acute pain situations, obviously you can lower the distress of the patient by lowering their pain level. So if you treat somebody in the ER who's got a fractured femur or a new MI or any other dramatic acute pain problem, you are actually able to address the emotions by reducing the pain. But unfortunately, that does not seem to be so obviously true with chronic pain. Ajay Wasan did a study showing that actually, in a pretty nicely controlled experimental study, depression was associated with reduced response to acute opioid treatment of discogenic back pain. And there have been other indications that depression reduces the response to chronic opioid treatment. We did a large pharmacoepidemiology study in the early 2000s, and paradoxically, depression increases the likelihood that people are going to be getting chronic opioid therapy in both publicly funded and privately insured patients. It occurred in all sorts of different health systems. Many other people have replicated this finding, so that even though depression looks like it does make opioids work better, it does increase the likelihood of getting opioid therapy. And you can kind of see that we measured 2 health systems over a period of time, and the basic message here is that the dark blue lines, they're higher, they're going up faster, and so anybody with a mental health or a substance use problem tends to get more chronic opioid therapy. We did another study with Group Health and Kaiser and found that both initiating and continuing opioid therapy rates were about 3 times higher in people that had a history of depression, and they also got a higher dose, greater day supply, and they got more potent Schedule II opioids. So that raises the question about can you treat depression with opioids? I've had many patients tell me, "Doc, if you just treated my pain, my depression would go away." And they don't say with opioids, although that's often implied, but it has been looked at. And in fact, opioids were recommended treatment for melancholia, mania, and other distress in the late 19th and early 20th centuries, because opioids were about the only psychotropic drug around then. And there are some recent, brief, and small trials that have examined opioid treatment of depression. Some of them are cited as evidence that you can treat depression with opioids, but when you drill down into them, they're studies of very low quality and not really any of them robustly showing that you can treat depression with opioids. The Varga trial was 12 patients for 3 weeks. 1 of them improved when codeine was added to a tricyclic. The Emmerich trial, which was an RCT with only 10 patients with buprenorphine, half were improved. That's probably the most convincing one, and there is a recent paper from the American Journal of Psychiatry suggesting that buprenorphine could be some interesting addition for treatment-resistant depression, maybe related to the fact that it's a kappa agonist, but that story is, I think, still got years to develop. And in general, we've summarized the fact that opioids appear to have a rapid but transient effect on mood, but there is really no evidence that they're an enduring, effective treatment for mood disorders. The relationship between depression or opioids and depression is multifaceted. Like I mentioned, other investigators have shown that depression predicts the persistence of opioid therapy. You have to remember that the vast majority of people started on opioids for chronic pain don't reach the 90-day threshold for making a chronic therapy. They quit. So there's a very self-selected group that goes on to be on chronic opioid therapy, and depression is one of the things that predicts that. But it's also a predictor of ambivalence about opioids, meaning that people will say, well, I think this is helping my pain, but I really wish I could cut back. Why this is, we don't really know. Maybe it's because of that Ajay Wasan finding that there's less effectiveness. But it's also interesting to know that I've been part of a research group at St. Louis University that's now published 3 or 4 papers on diverse chronic pain samples suggesting that opioid treatment increases the risk of major depression in chronic pain samples. And it looks like the duration rather than the dose of opioid therapy is the crucial variable, meaning that when you get into the over 90-day group, that's where you start seeing the increased rates of depression. So does depression increase the risks of treating chronic pain with opioids? Yes. It's associated with increased opioid misuse. Ajay Wasan again published a paper about that. Major depression and previous psychotropic drug use increased the risk of opioid dependence, meaning at that time that was DSM-4, that means opioid addiction essentially, in people getting long-term opioid therapy. And then even among older adults who are considered to have lower risk of addiction, high levels of depression are associated with opioid misuse. Chronic pain and sleep disturbance. This is an area, this is sort of the ripe, fertile ground for the growing of depression problems. I think oftentimes chronic pain morphs into depression through sleep disturbance. 50 to 80% of patients with chronic pain have a significant sleep disturbance. We know that disruption of slow-wave sleep increases pain sensitivity, and clinical studies show a good back and reciprocal relationship between sleep disturbance and pain. And in the depression literature, it's pretty clear that if you get people's mood better, they're feeling more hopeful, maybe more energetic, but they've still got persistent insomnia, that group is more likely to have a depression relapse or persistence. We did look at depression and opioid misuse among people getting chronic opioid therapy. This was a sample of 1,300 patients getting chronic opioid therapy at Group Health and Kaiser Permanente. None of them had a history of a substance use disorder. The group was pretty middle-aged, white, married, and female, like a lot of chronic opioid therapy. They had pain ratings in the mid-range between 3 and 5, and most of them had pretty low PHQ-8 scores. This was the PHQ-9 without the suicide item. And you can see here that as you go up from none to mild to moderate to severe depression, there's much more likely of using opioids for non-pain symptoms, specifically sleep problems and stress problems. They're more non-adherent, meaning that they will ask for early refills, they'll self-escalate their dose, but they don't tend to do the more aberrant behaviors like giving away or selling their meds or getting meds from other patients. They'll stick to their own prescriptions. So, in conclusion, depression is very common in patients with chronic pain, particularly those with severe, disabling, or multifocal pain. Depression and chronic pain impede each other's treatment. Opioids aren't the answer, partly because they don't provide sustained benefit for depression and in fact look like they increase the risks of depression. But the good news is that some of the very same kind of treatments, non-medication treatments, social and physical reactivation, are both known to work well for both depression and chronic pain.